Good day, everyone. My name is Dr. Haitham Mekkawi, and I welcome you to this teaching session on the recognition and management of cardiac tamponade within the fields of anesthesia and critical care. Cardiac tamponade is a life-threatening condition caused by the rapid accumulation of fluid in the pericardial space. When this pressure rises, the heart is unable to fill properly, leading to a dramatic fall in cardiac output and eventually cardiovascular collapse. In this lecture, we will explore how to recognize tamponade early, how to identify its characteristic clinical signs, and how to manage it safely and effectively, both inside the operating room and in the intensive care environment. Before diving deeper, let us begin with a real clinical scenario because tamponade is not an academic concept. It is a condition you may face suddenly, often with very little warning. A middle-aged man arrives in the emergency department after a road traffic accident. He is tachycardic, restless, and complaining of severe shortness of breath. His jugular veins are distended, his heart sounds are muffled, and his blood pressure is falling with each breath, a classic pulsus paradoxus. Within minutes, his condition deteriorates into profound hypotension. This is tamponade until proven otherwise. This session will therefore focus on the key clinical features you must recognize: muffled heart sounds, distended neck veins, hypotension, tachycardia, narrow pulse pressure, and pulsus paradoxus. These signs are not random. They reflect the physiology of a heart struggling against rising pericardial pressure. Our aim today is very simple: to help you detect tamponade quickly, act decisively, and save a life before the heart gives up. Let us begin. Before we move further into the diagnosis of cardiac tamponade, it is essential to understand the classical group of clinical findings that guide our recognition of this condition. This group is known as Beck's Triad, and it remains one of the most important bedside indicators of acute tamponade. The first component of Beck's Triad is hypotension. As fluid accumulates within the pericardial sac, the ventricles are unable to fill adequately during diastole. This leads to a sharp decline in stroke volume and, consequently, a drop in systolic blood pressure. The pulse pressure becomes markedly narrowed, and the patient may appear pale, cold, and in a state of shock. The second component is jugular venous distension. Because the heart cannot accept normal venous return, blood backs up into the venous system, raising central venous pressure. Even in a sitting position, the jugular veins remain visibly distended, reflecting the degree of obstruction to cardiac filling. The third component of the triad is muffled or distant heart sounds. As the pericardial space fills with fluid, the sound of the heart becomes dampened. Instead of the clear, crisp tones normally heard through the stethoscope, the heart appears quiet or far away, almost as though it is insulated from the chest wall. When these three findings are present together, hypotension, distended neck veins, and muffled heart sounds, the diagnosis of cardiac tamponade becomes highly likely. However, it is important to remember that not every patient presents with all three elements, especially in trauma or postoperative settings. Beck's Triad, therefore, serves as a powerful clinical signal. Signals to act quickly, initiate appropriate resuscitation, and prepare for urgent pericardial drainage. Recognizing these signs at the bedside can be the pivotal moment that prevents cardiac arrest and saves a patient's life. Among the most important clinical signs of cardiac tamponade is a physiological phenomenon known as pulsus paradoxus. Despite its name, there is nothing paradoxical about it. It is simply an exaggerated drop in systolic blood pressure during inspiration. Under normal circumstances, systolic pressure falls slightly when we breathe in. However, in cardiac tamponade, this drop becomes greater than 10 millimeters of mercury, and this exaggerated fall reflects severe impairment of cardiac filling. To appreciate why this occurs, let us consider the underlying physiology. During inspiration, negative intrathoracic pressure draws more blood into the right ventricle. But when the pericardial sac is filled with fluid, The heart cannot expand outward. Instead, the right ventricle pushes the interventricular septum toward the left ventricle, reducing left ventricular filling. As a result, the systolic pressure drops significantly with each breath. At the bedside, this can be detected using a manual blood pressure cuff. When the cuff is slowly released, the Korotkov sounds may be heard only during expiration and disappear completely during inspiration. This respiratory variation confirms the presence of pulsus paradoxus. In the context of trauma, postoperative cardiac surgery, or pericardial disease, pulsus paradoxus becomes a critical warning sign. Its presence should immediately prompt the clinician to consider cardiac tamponade and to proceed with urgent diagnostic imaging or intervention. In many hospitals across Khartoum, including Soba University Hospital and Ibrahim Malik Teaching Hospital, clinicians rely on this sign when echocardiography is not readily available. Ultrasound plays a central role in the diagnosis of cardiac tamponade, and it is often the single most important investigation when clinical suspicion is high. In acute tamponade, the first abnormality we recognize is right atrial collapse during diastole. Because the right atrium is a low-pressure chamber, it is the earliest structure to be compressed by rising pericardial pressure. As the effusion becomes more severe, the right ventricle begins to collapse during early diastole. This collapse is a highly specific sign, and when present, it strongly indicates that the heart is no longer able to fill adequately. A large circumferential pericardial effusion is typically visible. The heart may appear to be swinging or shifting within the fluid-filled sac, especially in cases where the volume of fluid is extreme. Another key finding is a plethoric inferior vena cava that shows very little or no collapse during inspiration. This reflects elevated right-sided pressures and impaired venous return, both classic features of tamponade physiology. In many hospitals across Khartoum, including resource-limited settings, bedside echocardiography has become indispensable. It allows clinicians to confirm tamponade rapidly, assess its severity, and guide the safest approach for pericardiocentesis. Understanding these ultrasound features is vital. They bridge the gap between clinical suspicion and definitive diagnosis, ensuring that the patient receives timely and life-saving intervention. Understanding the pathophysiology of cardiac tamponade is essential for recognizing the clinical signs and responding effectively. Cardiac tamponade occurs when fluid accumulates within the pericardial sac, creating a progressively rising pressure around the heart. This pressure begins to exceed the filling pressure of the cardiac chambers, particularly the right atrium and the right ventricle, which are the lowest pressure chambers. As the pericardial pressure increases, the heart is no longer able to expand during diastole. This results in impaired ventricular filling, reduced stroke volume, and a rapid fall in cardiac output. The body attempts to compensate through tachycardia, vasoconstriction, and increased sympathetic activity. However, compensation is limited, and once these mechanisms fail, the patient enters obstructive shock. The characteristic narrow pulse pressure seen in tamponade is a direct reflection of reduced stroke volume. At the same time, central venous pressure rises because blood cannot enter the compressed right side of the heart. This is why jugular venous distension becomes such an important clinical sign. The interventricular septum also plays a major role. Under rising pressure, the right ventricle shifts the septum toward the left ventricle during inspiration. This reduces left ventricular filling and causes the exaggerated drop in systolic pressure known as pulsus paradoxus. When the pericardial pressure equalizes with the diastolic pressures of all four cardiac chambers, the heart becomes fixed in a state of critically limited filling. At this stage, even small increases in fluid volume can trigger sudden cardiovascular collapse. Once cardiac tamponade is recognized, the immediate priority is stabilizing the patient while preparing for definitive intervention. The first objective is to support circulation. This is achieved by administering intravenous fluids to increase venous return and maintain preload. Increasing preload temporarily improves cardiac output by helping the ventricles partially overcome the external pressure exerted by the pericardial effusion. At the same time, it is essential to maintain an adequate heart rate. In cardiac tamponade, the stroke volume becomes critically reduced, and the body depends heavily on an elevated heart rate to sustain cardiac output. Any medication or intervention that depresses the heart rate can precipitate further deterioration, so clinicians must remain vigilant. If the patient is hypotensive or shows signs of shock, emergency pericardiocentesis may be required. This procedure relieves intrapericardial pressure and can be life-saving, especially in acute traumatic tamponade or rapidly accumulating effusions. During this period, patients should receive high-flow oxygen to optimize tissue oxygen delivery. In addition, maintaining sinus rhythm is vital because the loss of atrial contraction further reduces ventricular filling in an already compromised heart. As resuscitation progresses, the clinical team should prepare for definitive management, which may involve surgical pericardial window or pericardiectomy, depending on the underlying cause. In summary, immediate management focuses on three goals: supporting preload, maintaining heart rate and rhythm, and relieving pericardial pressure when necessary. These actions stabilize the patient and create the physiological conditions needed for definitive treatment. Pericardiocentesis is a life-saving procedure that provides rapid relief of cardiac tamponade by removing fluid from the pericardial space. In emergency settings, especially when hemodynamic collapse is imminent, it must be performed quickly, safely, and with a structured approach. The first step is patient positioning. The patient should be placed in a slightly elevated, semi-recumbent position at approximately 45 degrees. This angle allows the effusion to collect anteriorly, creating a safer access window for needle insertion. The second step is monitoring and preparation. Continuous electrocardiography, oxygen supplementation, and intravenous access must be established. Whenever possible, the procedure should be performed under ultrasound guidance to identify the largest and safest fluid pocket. The third step is site selection. Two approaches are commonly used: the subxiphoid approach and the parasternal approach. The subxiphoid technique is most frequently used in emergencies because it avoids the coronary arteries, internal thoracic vessels, and lungs. The fourth step is needle insertion. Using a long spinal needle attached to a syringe, the needle is advanced at a shallow angle of 30 to 45 degrees, aiming toward the left shoulder. Aspiration is performed continuously during advancement. Entry into the pericardial space is indicated by free aspiration of non-pulsatile fluid. The fifth step is confirmation of placement. Electrocardiographic monitoring may show ST segment elevation if the needle contacts the myocardium, prompting immediate repositioning. Ultrasound visualization provides the highest level of safety. Once the needle is correctly positioned, the sixth step is drainage. Pericardial fluid is aspirated slowly to restore cardiac filling. Rapid removal of large volumes may cause hemodynamic instability, so controlled removal is essential. In many cases, a soft catheter is threaded over the needle to allow continuous drainage. The seventh step is post-procedural monitoring. Hemodynamic parameters must be reassessed immediately. A repeat ultrasound confirms adequate drainage and identifies any remaining fluid or complications. Pericardiocentesis is highly effective when performed correctly, but it carries risks such as pneumothorax, ventricular puncture, arrhythmias, and injury to the coronary vessels. For this reason, training, preparation, and CAM execution are essential, especially in resource-limited settings where ultrasound or surgical backup may not always be available. This structured, step-by-step approach ensures that pericardiocentesis is performed safely and efficiently during cardiac tamponade emergencies. Electrocardiography provides several important clues that support the diagnosis of cardiac tamponade, particularly when combined with clinical findings and bedside ultrasound. The first characteristic finding is sinus tachycardia. This represents a compensatory response to the reduced stroke volume. As cardiac filling becomes impaired, the body attempts to maintain cardiac output by increasing the heart rate. The second classic feature is low-voltage QRS complexes. Because electrical signals must traverse an increased layer of pericardial fluid, the amplitude of the QRS complexes becomes smaller. This low-voltage pattern is often most pronounced in the limb leads. One of the most distinctive patterns in cardiac tamponade is electrical alternance. This refers to beat-to-beat variation in QRS amplitude or axis. The swinging motion of the heart within the fluid-filled pericardial sac produces this alternating electrical pattern. Electrical alternance is not always present, but when observed, it is highly suggestive of significant pericardial effusion. Another important finding is the presence of nonspecific ST segment or T-wave abnormalities. These may reflect ischemia secondary to reduced coronary perfusion or the effect of chronic pericardial irritation. Occasionally, patients may display pseudo-low-voltage patterns if there is concurrent obesity, chronic obstructive pulmonary disease, or large body habitus. These conditions also reduce QRS amplitude, so interpretation must be guided by the clinical context. It is also important to note that a normal electrocardiogram does not exclude cardiac tamponade. In some patients, particularly those with slowly accumulating effusions, echocardiographic changes may be subtle or absent. In summary, the most important electrocardiographic clues to cardiac tamponade include sinus tachycardia, low-voltage QRS complexes, electrical alternance, and nonspecific repolarization changes. When these findings are combined with clinical features such as pulsus paradoxus, hypotension, and elevated jugular venous pressure, they significantly strengthen the suspicion for tamponade and guide clinicians toward urgent diagnostic imaging and intervention. Pharmacological principles in cardiac tamponade. Before selecting any medication for a patient with cardiac tamponade, it is vital to remember that this condition represents a state of fixed and critically reduced stroke volume. Any intervention that lowers systemic vascular resistance, decreases venous return, or depresses myocardial contractility can precipitate cardiovascular collapse. The primary objective is to maintain forward blood flow until the pericardial sac is drained. For this reason, medications that support heart rate, preserve preload, and maintain systemic blood pressure are preferred. Induction of general anesthesia is especially hazardous. Many commonly used agents, such as propofol or thiopentone, cause significant reduction in systemic vascular resistance and myocardial contractility. This sudden decrease in afterload and contractility can lead to an immediate fall in arterial pressure that the compromised heart cannot compensate for. Ketamine is considered the induction agent of choice because it supports heart rate and maintains systemic vascular resistance, thereby sustaining cardiac output in the moments before surgical relief of the tamponade. Analgesic agents that depress respiration or blunt the sympathetic response must be used with caution. Excessive sedation reduces venous return and further restricts cardiac filling. It is safer to maintain the patient awake, responsive, and breathing spontaneously until the pericardial sac is opened. Vasopressor support may be required. Agents such as norepinephrine or epinephrine help maintain perfusion pressure without excessively reducing venous return. Pure vasodilators and calcium channel blockers must be avoided because they worsen the hemodynamic compromise. In summary, the pharmacological strategy in cardiac tamponade is simple but extremely delicate. Maintain preload, maintain heart rate, maintain systemic vascular resistance, and avoid myocardial depression. Every drug choice must be guided by these principles until surgical decompression is achieved. Airway and ventilation principles in cardiac tamponade. When managing a patient with cardiac tamponade, securing the airway must be approached with extreme caution. The moment positive pressure ventilation is initiated, intrathoracic pressure rises. This rise in pressure reduces venous return to the heart, a heart that is already struggling to fill due to pericardial compression. For this reason, spontaneous ventilation should be maintained for as long as possible, ideally until the pericardial sac is opened. If intubation becomes necessary, it must be rapid, controlled, and executed with minimal hemodynamic disturbance. Use gentle ventilation with small tidal volumes and the lowest effective airway pressures. Avoid excessive PP, because even small increases in intrathoracic pressure can dramatically reduce cardiac output. Capnography becomes a crucial guide. A falling end tidal CO often signals worsening cardiac output, while a sudden rise may indicate return of circulation. Throughout this process, the goal is the same: preserve venous return, maintain forward flow, and avoid any intervention that further impairs cardiac filling. Only after the pericardial sac is drained can controlled ventilation safely resume without risking cardiovascular collapse. I almost forgot. Before we conclude, let's take a quick look at the differential diagnosis of cardiac tamponade. Not every case of hypotension with distended neck veins and muffled heart sounds is tamponade. Several other conditions can appear very similar. First, acute myocardial infarction. ET may cause hypotension and elevated venous pressure due to poor cardiac contractility, but the ECG shows ischemic changes, not electrical alternance. Second, aortic dissection. A ruptured ascending dissection can lead to hemopericardium and tamponade, but pain is usually abrupt, tearing, and radiates to the back. Next, trauma. Both blunt and penetrating chest trauma can cause cardiac rupture or pericardial bleeding, producing signs identical to tamponade. Pericardial effusion deserves special mention. A slow-developing effusion may cause similar findings but allows time for pericardial stretching, so symptoms appear late. Finally, iatrogenic causes such as pacemaker insertion, catheter perforation, or post-cardiac surgery bleeding. Always consider these in postoperative or interventional settings. So remember, when you encounter Beck's triad, think broadly. Tamponade is an emergency, but look for these mimics before you act. Thank you for watching. If you found this lecture helpful, please don't forget to hit like, share it with your friends, and subscribe to our channel for more educational content. And if you'd like to explore more lectures, clinical notes, and recorded courses, you can always pay us a visit at our website at AnesthesiaSD. Once again, thank you for your time and support. Then I look forward to seeing you in the next session.